aspart compared to regular human insulin, undergoing ICU monitoring post-cardiac surgery and Indian experience. This is again being explored by the makers of aspart now who are using aspart. Well, we just concluded in this study that there is similar safety of IV aspart as compared to IV regular human insulin, and physicians found it easier to use it, especially when you have to transition from IV to subcutaneous. It may be better to start with aspart and continue that. Then this was the work in 2016, which was about the effects of vildagliptin related to sulfonylurea in Muslim patients fasting during the Ramadan period. Again, this was one of the other international collaborations that I was associated with, and we showed here that vildagliptin as compared to sulfonylurea, whether used alone or in combination with metformin, had lesser amount of hypoglycemia during the fasting period and also better A1C reduction. So few patients in the vildagliptin group experienced hypo, far fewer than those in sulfonylurea group, and found that vildagliptin may be a safer option to sulfonylureas for patients who are fasting, be it Ramadan or any prolonged fasting. As I said, the phase was technology, so we came into the phase of CGMs and started using CGMs much earlier in the country. This was the first collaborative study in India, which was use of retrospective CGM for optimizing management of type 2 diabetes in India. And in this earlier study itself, which was again 2016 when this was published in JABI, IPRO2 studies provided healthcare practitioners with insights and opportunities for initiating changes to treatment regimens and to diet and exercise behavior, and provided patients with improved knowledge of the importance of therapy compliance. So CGM back then we established in 2016, it's 2024, and we still keep talking about the relevance of CGM and why it should be done more. Well, then we also started focusing, and this was the time that insulin usage was increasing, and it was important to also focus on the injection technique. And though I've been a part of the forum for injection insulin technique, I'm sorry to say even today, across the globe and in India, we come across patients who've been taking insulin for several years but never taught correct insulin technique. So through the medium of this oration, let me again appeal to all of you, clinicians, paramedics, educators, nurses, please ensure correct insulin technique for your patients. It's one of the biggest factors why patients don't respond. As my personal journey grew, I was extremely happy to be felicitated by the RSSDI fellowship. This was in 2017 in Orissa. We can see Dr. Jayant Panda here, who was up here on the stage. Dr. Shaukat Sadikot was there, Dr. Sarita Bajaj, Dr. Rajiv Chawla. So I was happy to be there in 2017, doing my work in delivering lectures and also being honored with the felicitation. Again, in the newspaper quotes, if you see on the right side, it's us talking about CGM. So 2016-17, we started focusing more on technology and the need for better and close monitoring through CGM. At the same time, it was a period when combinations started coming in. And this was a pan-Asia study that I'm extremely proud about, called the initial study, which was initial combination therapy with vildagliptin plus metformin in drug-naive patients, a 24-week real-life study from Asia, where we concluded that in relatively young drug-naive type 2 patients, even with high baseline A1C and associated with cardiovascular risk factors, the vildagliptin metformin combination was associated with significant and clinically relevant A1C reduction from baseline. And this was seen at week 12 and maintained over the 24-week period. So what did this study show was, the West often tried to tell us your patient comes with an A1C of 10.5%, drug naive, start insulin. Well, you need to individualize and look at who needs it, who doesn't. There will be enough patients there who are without symptoms, are not toxic, and even at the 10.5% A1C, especially the drug naive ones with diet, exercise and a combination of DPP-4 metformin, a large number of them will come to 7% and below, and that's what is the clinical trend today. This was the POCT time. I'm sure many of us use POCT. Again, happy to be part of this group with Dr. Makkar and Banshi and others, where we spoke about recommendations for in-clinic point-of-care testing. At our center in Mumbai, a lot of tests now can be done with the point-of-care devices, which turn out to be a boon because of faster results and easier way of doing it for the patients. Now this was again looking at the combination of metformin and the extended release metformin. In India, we have taken steps to come out with different sustained release and extended release preparations. Again, a technological advance, and happy to be associated where we showed that the technologically advanced formulation of metformin, this extended release tablets, improved adherence, compliance, satisfaction and lesser side effects. 2019, well, we started focusing on other aspects, and one of this was euthymia. Now, what is euthymia? It's actually related to diabetes distress, and today, with the advent of various drugs and how we treat diabetes, we should not forget that who are we doing it for. It is the patient at the center of everything, and the patient's happiness and lack of distress should also be the goal that the clinician have. And this is what we tried to say through this paper headed by Sanjay Chawla at that time, that look at diabetes euthymia or look at reducing diabetes distress, whether it is through compliance of medications, non-strict, non-stringent advices and catering to the individual needs. Well, the insulin wars were heating up, and this was one of the papers which spoke about the B-Smart basal early strategies to maximize A1 reduction with oral therapy. Again, we came out with clear recommendations of initiating basal insulin, and this could be with LPH, Glargine 100, Degludec, Detamir or Glargine 300. So all the current basal insulins available, very, very clear in this paper. We again then went back because we saw that the West was trying to deter the use of sulfonylurea. In all their recommendations, they were throwing out sulfonylureas. So in 2019, again this group came together to focus on the glucocrinology of modern sulfonylureas, and we came out with a clinical evidence and practice-based opinion from an international expert group, again highlighting that why sulfonylureas will continue to be important. An appropriate clinical judgment coupled with patient-centered approach is crucial, especially in Indian practice. Sulfonylureas in newer, modern, smarter sulfonylureas will always be relevant. Back again in 2019, we were part of the consensus recommendation on GLP-1 receptor use in the management of type 2 diabetes. This was a South Asian task force. GLP usage was still very limited in 2019. But yet back then we could come out with recommendations clearly telling what are the indications, the contraindications, and more importantly, how do you manage the adverse events. The things about starting slow and then gradually increasing the dose, short frequent meals, use of probiotics and so on was recommended by this group way back in 2019 itself. Well, India kept getting more and more gliptins. Evogliptin was one such drug which is still used and was part of this Evolution India study which compared evogliptin and sitagliptin, and we concluded that evogliptin was non-inferior to sitagliptin in A1C reduction. So as our journey in diabetes continued, it was coinciding with India's strengths in creating own science and data for the world. We then were a part of the consensus statement on use of AGP in patients with type 2 diabetes receiving oral anti-diabetic drugs. This is again way before the world accepted the recommendation for use of CGM and AGP in type 2. In 2019 itself, we were already showing evidence of the benefits of using CGM and AGP in type 2 patients, which I strongly recommend. The article aimed to discuss the consensus of the expert group on the role of AGP in type 2 patients and also review the various aspects of AGP and its interpretation. And this has continued to be the boon. Well, we continued our ride at the AD and the ESD congresses presenting our studies there. The Flozin era continued, and we were part of multiple recommendations looking at, again, basal insulin recommendations based on the Delphi method, or being part of the remogliflozin study which was pitched as an Indian SGLT2 inhibitor showing its non-inferiority to dapagliflozin. This was of course done by Glenmark and was again happy to be part of the author block, being a principal investigator for this drug, showing remogliflozin was non-inferior to dapa. Again, while we were continuing our journey looking at different drugs, it was also important to assess how are we doing overall as a nation. What is the level of control? And this data, the IDMPS2 led by Dr. Ramchandran, again happy to be part of the IDMPS study, a pan-India author block here. And what we showed was in subjects with type 2 diabetes essentially, A1C less than 7% was noted in only half the subjects receiving insulin and in much lesser receiving only the oral glucose drugs. Lack of experience in self-managing insulin dosing, poor diabetes education and failure to titrate insulin were the main reasons for non-achievement of goals. We then came out with the joint statement with the Indian Periodontology